Morning, we're here with Piterman. Leon, you've got quite an extensive background. You're the Professor of General Practice and Pro-Vice Chancellor at the University. What else is your background?
Well, my background really is clinical general practice, and I'm pleased to say that throughout all of those career changes, I've continued to maintain clinical general practice. And so I still do 2 half days a week, and most of my patients are those that I originally, or many of them that I originally met 30 years ago or more, and have grown old with me, and have grown with a lot of clinical problems, and so I still look after a cohort of very elderly patients with chronic disease. Okay,
so quite a varied scope that you have going on. Okay, and you're here today to do quite a few talks, isn't it?
Yeah.
One of them is it was quite an interesting topic, was the dying art of medicine.
Yeah.
In relation to technology.
That's right.
Okay, that's for me going to be quite an interesting talk. Being I'm from a younger generation, I've just started out as a doctor. I think I embrace technology quite a lot, but you're coming from the other side of this art of medicine that you talk about. Can you tell me a bit more about your talk?
Well, the art of medicine needs to be balanced with the science of medicine, and science, of course, spawns technology. And I'm not opposed to technology. What I am opposed to is the unfettered use of technology at the expense of clinical assessment. And art is about the person, the patient, understanding the person, understanding the patient. Science is about understanding the disease, and technology helps us to understand the disease, but it really helps us to understand the person. And in general practice, we need to have a blend of both. So what has happened is that clinical assessment and examination, for example, in neurological conditions, has been put to one side. In turn, CT scans are done routinely for headaches.
Okay.
We know that most headaches don't deserve a CT scan. Back pain is investigated with MRIs, when we know that in most cases whatever changes occur on the MRI are not necessarily explaining the back pain. So there's a huge cost associated with all of this, and that cost is blowing out health budgets, and so we're spending in Australia, for example, now 10% of GDP on health. It used to be 7% 15 years ago. In the United States it's 17%. So it's becoming very, very expensive. So I think we need to restore a sensible, evidence-based clinical approach to assessment, and that is really ensuring that the art and the craft of medicine are not forgotten at the expense of embracing technology.
And of course there's the other side of the argument is clinicians are expensive as well, and so having technology to do some of the work that clinicians could do could be of course cost saving and time saving for them. One of the things that I find, although I've only just started out being a doctor, is there's a lot of algorithms that are in clinical practice. So a patient can present with symptoms and a range of like lab results and things like that, and that could be placed into an easily adaptable algorithm that a technology could easily replace a clinician with. That's one of the fears, I guess, that we've got coming up in the future.
I've never thought that technology will replace the human contact.
Of course.
You know, one of the areas of interest I have is somatisation and somatoform disorders, and I went yesterday to an interesting talk by a general physician, a physician who specialises in general medicine, and he talked about the range of people that he sees, and we see more of those sort of patients in general practice with somatic symptoms for which there is no physical cause, and they are investigated again and again and again. But unless we understand a little bit more about them and the factors that have influenced the development of their somatic symptoms, technology is not going to help us in that direction.
That's something that definitely you can't replace, can you, with technology, is that one-to-one personal interaction.
That's right.
And particularly in mental health presentations.
And general practice has got the advantage of helping us. We know families. We often treat 3 or even 4 generations, and so we can understand the context in which illness may develop, especially when there's trauma associated with some of the family dynamics. Okay.
And one of the other talks that you have on today or yesterday was you discussed some cases in mental health.
Yeah.
Which I think was quite a popular talk. It was both sessions were full.
Seemed to be well attended. So
Yeah.
I presented the case of a young man, a 22-year-old man, whose girlfriend was very concerned about his change in mood, and in fact he was an example of a person with major depressive disorder.
Okay.
But in a young man who has used a bit of ecstasy, who occasionally binge drinks, who's having difficulty with his work patterns because there is some irregular attendance at work, it raises concerns. And while major depressive disorder was in fact the diagnosis, other conditions such as bipolar disorder and particularly bipolar depression need to be thought about because the treatment is rather different. And also with his use of drugs, one needs to consider early onset psychosis. So it was a case that opened up a whole range of discussions about diagnostic possibilities, but also therapeutic and pharmacological and non-pharmacological. And these young men are often at high risk. The risk of suicide, and so we talked about suicidality, and in bipolar depression, 30% suicide risk, it's 3 times as great as in unipolar. So these are the kind of issues that we talked about. The other case, which I didn't really have time to talk about because depression occupied the full hour, was on post-traumatic stress disorder. And that is a major emerging problem in our community. And in this town, of course, in Christchurch, the earthquake has left a lot of people traumatised, even till today. But we see it in domestic violence, we see it in child abuse. It's not just about war, and it's not just about people working in emergency services, although they, of course, suffer quite a deal.
It's a shame. So that was one that you didn't get to cover yesterday.
No, I would have liked to do that, but there's only time to do a few things.
Okay, all right. Well, speaking of time, I guess I'm going to let you get to your next talk.
Thank you, Kerry. It's been nice chatting with you.
Yeah, thank you very much.
You.
Okay.